Bonjour tout le monde, très heureuse de vous retrouver pour cette je ne sais pas combienième école d'automne de la Fondation fondamentale. Aujourd'hui, donc avant-dernière de conférence sur les biomarqueurs dans les maladies mentales, avec les biomarqueurs de l'inflammation, depuis ce qui se passe en recherche jusqu'à ce qui se passe en consultation ou au lit du patient. Et j'ai le très grand plaisir de vous présenter aujourd'hui Livia de Picker, avec qui je travaille depuis très longtemps, je ne sais plus très bien combien de temps, qui est psychiatre, qui est spécialiste en immunopsychiatrie, qui est maintenant professeur d'immunopsychiatrie en Belgique à l'université d'Anvers, où elle s'occupe d'un département, je ne sais pas si elle aura l'occasion d'en parler, surtout sur les patients borderline. Et elle va nous parler aujourd'hui donc de sa spécialité qui est l'immunopsychiatrie. Elle est aussi devenue le directeur du réseau CNP d'immunopsychiatrie que j'ai créé il y a longtemps et dont maintenant je suis le vice-président avec Livia qui est donc présidente. Elle a aussi beaucoup travaillé, je pense qu'elle va vous en parler, sur les données qui sont réunies dans les bases FACE et les analyses de biomarqueurs avec des résultats super intéressants que vous avez peut-être vu passer dans les papiers et qu'elle va vous présenter. Et je pense qu'il y a tellement d'impact et tellement d'espoir avec l'exploration de ces marqueurs et des innovations thérapeutiques qu'on est très, très, très heureux de donner la parole à Livia. Livia, alors, j'ai oublié de dire que Livia parle français comme vous et moi. Sa maman est prof de français, mais elle va vous parler en anglais. Mais bien sûr qu'elle pourra répondre aux questions en français. Peut-être qu'on aura le droit à une petite phrase d'introduction en français si on a beaucoup de chance.
C'est vraiment un grand plaisir d'être ici avec vous. C'est tout à fait correct d'être ici face à face avec vous. C'est beaucoup mieux d'être hybride sur l'ordinateur. Je continuerai en anglais parce que je me sens plus à l'aise comme ça, mais si vous voulez me demander des questions tout à l'heure en français, on se débrouillera. Ça va. OK. So, biomarkers. For immunopsychiatry or for inflammation, I've been asked to talk about this topic with you, but I feel maybe not the best person in the room to do that because we have the chief experts actually sitting here in the front row. But I'll try to give you some overview. These are my disclaimers. And here's an outline of my talk. So, as a clinician myself, rather than giving you just an overview of 100 different type of markers and how we measure them and all of that, I want to really talk first about the clinical framework. Why is this important, right? And what can we do with this in clinical practice? So I start from the precision psychiatry framework. I'm sure you've heard about this before because Marion never stops talking about it. But so this is the new way forward in psychiatry and in mental health. Then types of biomarkers. What is a good enough biomarker? Immune biomarkers, and then one specific example of what we are doing in clinical trials right now. But so, very briefly, precision psychiatry. Whenever I go to big conferences, and I attend several ones many times per year, I always feel somewhat frustrated because on the one hand, there is such innovative, fantastic new science being presented there, all these new findings of the genetics and the microbiome and biomarkers and all of that. And at the same time, we are still stuck in this cage that we created for ourselves, basically, of our categorical diagnostic classification. And it's so hard to bring these new findings of neuroscience into clinical practice. And I think it's not for lack of trying. This is a PubMed search of papers on psychiatry and biomarkers. And you can see even just in the last 10 years that so much work is being published on this topic, 25% about immune and inflammation markers. So we are trying, scientists are trying very hard to find new findings. Oops. But as shown here in this paper from 2 years ago. The critical gap remains in validating, in then bringing that from scientific findings into clinical practice, and this is where we keep getting stuck, and we need a new mechanism, a new approach to change things. This picture was created from the ECNP. ECNP is the largest neuroscience organization in Europe. They also feel the same frustration. They also agree that something needs to change and we need to move away from DSM categories. And they've created, and Marion is collaborating on this roadmap for precision psychiatry, where starting from a heterogeneous group of patients, all with their own symptoms and backgrounds and histories and contexts, and then through assessments in multiple ways, looking at symptoms, digital tools, behavior, cognition, imaging, cells, context, try and stratify them in such ways that we are better able to treat them in a personalized way. This is the future, of course, but I think the work that you are doing already today will be a big part of making this happen. Now, coming back to biomarkers. I was talking about this talk with one of my friends before, and he's completely from outside of science and psychiatry, and his first question is, what is actually a biomarker? I said, well, that's a good question. How do we define a biomarker? And in fact, I think whenever we talk about different types of biomarkers, we get stuck in translation. Like we need to first define some of the words that we use before we know what we're talking about, because we can classify biomarkers in different ways. One of them is by source. Where do we measure the biomarker? Do we measure in blood, in cerebrospinal fluid, saliva? Do we measure symptoms? So there's different sources. There's also different biological substrates, like we can look at the genes, the translation of the genes into the proteins. We can look at antibodies, metabolites, enzymes. So these are all different types of biological pathways. We have different methods of analyzing. We can do imaging or clinical, digital, soluble markers. The reasons why we use the biomarkers may also be different: prediction, diagnosis, prognosis, and then, of course, different target populations, people with depression, people with psychosis problems, etc. So in order to define the type of biomarker, we need to answer all 5 of these questions to, really know what we're talking about: the where, what, how, why, who. So in the future, I think whenever we talk about biomarkers, we should try and put it in a phrase like here, the way that we also do for clinical trials. Placebo-controlled, double-blind, randomized clinical trial, and similarly, it could be blood-based, predictive, epigenetic marker of treatment-resistant depression, something like this. I think would be helpful to have the same language. And then before I continue, I'm going to take a little moment to explain the different use cases, because I think this is the most important part to understand how this will help us in the future in clinical practice for psychiatry. So according to the FDA, the big American regulator of new medications, there are 7 categories for biomarkers in the whole of medicine. So this is not just for psychiatry. The first one is biomarkers for risk. For instance, the BRCA mutation for breast cancer. So if someone has this marker, if you're positive for that mutation, you have an increased risk to develop breast cancer. And similarly, CRP is a measure of inflammation that is a risk biomarker for coronary heart disease. And these examples all come from the FDA website, so these are recognized biomarkers for different purposes. A second use case could be diagnosis. So in this case, we are using a biomarker to identify the presence of a certain disease condition or a subtype of that disease. For instance, I think you know these quite well. We can look at HbA1c for diabetes type 2, but also something simple like measuring the blood pressure several times outside of GP office is a diagnostic biomarker for essential hypertension. So even simple things that we may not think of in terms of biomarkers can actually be biomarkers. And I think even in psychiatry, we are already using some of these. Monitoring, so here we will use a marker and measure it several times to follow up on a treatment, for instance, or how the disease changes over time. For instance, the INR for the warfarin treatment, where we want to make sure that it falls between a certain range, so we know that the treatment is working. Also, when someone has hepatitis C and we treat them, we want to see the hepatitis virus RNA go down, so we know that it works. Prognostic markers, this is about your outcomes of the clinical condition. So this is different from risk. You already have the condition, you've been diagnosed, but now we want to have an indication of what your outcomes will be. Will you respond to treatments? Do you have a higher risk of relapse? Do you have a higher risk of mortality? These types of things. Again, here CRP is a measure of inflammation that is also a biomarker for recurrent coronary disease. Predictive biomarkers, what is your chance of responding to treatment A instead of treatment B? So we have some of the markers more in cancer research, for instance, where choices are really being made between treatment 1 and treatment 2 based on your genetic profile. Pharmacodynamic or response, I think this is, for clinical trials, the most interesting one. If you get a marker approved by the FDA as being a marker of a surrogate marker of response, it means that the regulators feel that the marker is so closely tied to the clinical outcome that in your clinical trial, you no longer have to prove the clinical outcome. It's enough to just show that it works on the marker. For instance, if you want to make the claim that you have a new medication and it prevents stroke or it prevents myocardial infarction, it is enough to prove that it reduces the blood pressure. Then, if you can show it reduces the blood pressure, you can already make the claim that it's preventive for stroke, because it's a surrogate endpoint. Same for HIV treatment. If you have a new HIV drug, you just need to show that it reduces the RNA. You do not have to prove that people actually feel better or die less or anything like that, because it's recognized as a surrogate endpoint. In psychiatry, we have none of those. And the FDA has even said that they are unwilling to use any type of primary endpoint marker for clinical trials that is not patient-reported or related to patients' clinical outcomes. So here, I think we are a little bit stuck. But I think this could really help us move forward if we were to have some more objective type measures. Even clinical ones or digital ones or behavioral ones could be useful. And then finally, safety. I think this is less relevant here. I made an attempt to indicate some biomarkers that we are already using in clinical practice in some way. I have to admit, not all of them may be, depending on how narrow you want to define biomarker, are real biomarkers. I indicated in bold the ones that are more objectively measurable, whereas others are more like, from the anamnesis or from the family history or just types of information that we use. But still, I think a family history is a relevant marker. We stratify patients in our minds. We determine that someone would have a higher risk if they have also a family history. We take that into account. If we want to think about does someone have a diagnosis of bipolar disorder, a relevant biomarker would be to have objective evidence of a hypomanic episode or a manic episode. BMI and anorexia nervosa, I think this is very clearly definitely a biomarker that we're using. It's measurable. We use it to monitor the condition over time. Prognostic markers, cognitive worsening and schizophrenia over time, I think. The number of previous episodes in depression. Predictive, who do we give ECT treatment? Yeah, there are certain profiles of patients that we know in advance have a higher chance of responding to ECT. And that's why we like this treatment, because we can predict more or less who will have a higher chance of responding. Same with light therapy. We know to use this in people with seasonal patterns. It's not for everybody. And then also, I think, Parkinsonism in typical antipsychotics, if we see, objective evidence of dopamine block through the physical symptoms, then we know at least that something is happening in the dopamine receptors. Of course, we don't want the side effects, but it's a clear indication that the patient is taking the drug and that something is happening. And then neutrophils and clozapine. So I think I want to show this to you to indicate that all of these examples from cancer and from cardiovascular diseases, it's not that far removed from what we are doing already, but we could use additional and more biological measures, I think, on top of what we have. Okay, and then what could be our ambition in the future is to use maybe also immune biomarkers in psychiatry. And of course, not all biomarkers being developed are immune markers, but as I said, it's an important part and the part that I'm most interested in. And there are already lots of papers showing, biomarkers related to risk, to diagnosis, monitoring, prognosis. So all of these different biomarker categories we are looking into already with our investigations for immunopsychiatry, but none of them have been validated far enough in the pathway that we can already use them in clinical practice. And I'll explain why. Why are they not good enough, or what is actually good enough? You may be familiar with the concept of the good enough mother. I'm using here the same thing for the good enough biomarker. The perfect biomarker does not exist, and it doesn't exist in the rest of medicine either, right? So we typically think in psychiatry like, oh, our work is so much more difficult, and we are lagging behind. No, like if you talk to an oncologist, they will tell you just the same that, even with their very fancy genetic profiling, there are still lots of questions that they can't answer and lots of things that are unclear. And so the perfect biomarker doesn't exist. We shouldn't expect that, but it should be good enough. What is good enough? Well, 3 stars. The top important criteria that any good enough biomarker should meet is specificity, low false positives. If you score positive, we're sure that it's true, that it's really that you have the diagnosis or that you have the risk. It should be sensitive, low false negatives. If you score negative, then we need to be sure that it's really negative and that you don't have the risk. And it should be reproducible. If I take the same sample and I send it to 5 labs, I want the same results from all of them, right? And if I have the one sample and I split it in 5 and I send it to the same lab 5 times, I want the same result 5 times. It should be reproducible. If it already meets this first 3, then I think it's already good enough. But even better, if it's also easily measurable. If we can easily get it, if it's safe to get it, and if it's cheap, of course. Because if it's super complicated to get a sample, or it's super expensive to do the measurements, then also it's going to not be used that much in clinical practice. And then thirdly, I think this is the least important part, but preferably it should be associated with some known mechanism, and we should know more or less which range is corresponds to healthy and which range corresponds to abnormal or increased risk or whatever. But I think keeping in mind that we are moving towards also more machine learning and algorithms and more complicated biomarker structures, in the future we may not always have this part. And it's not really necessary either. Like if we know that if you score positive on test A, then your chance of responding to treatment B is better, we can use it, regardless of if we know how, right? The same for psychotic depression. We didn't have an idea before why psychotic depression responded better to ECT. We just see that it does, so we can use it. Okay, a little more in detail. So to meet the criteria of the good enough biomarker, we need broadly two types of things. We need the people who work in the lab and who develop all of these methods to really work hard on analytical and technical performance, right? So here it's a reliable test. We can reproduce it over time between labs. It's robust, which means that if you take the sample and you forget to put it in the fridge for 30 minutes, that it's not ruined, right? Or if the patient gets the sample at 8 in the morning or 6 in the evening, it should still be fine. So this is the robustness over time. It should be easy to measure and the dynamic range. So all of this, I think, is for the scientists who are working in labs. And then the second part is that it should have clinical relevance, of course. Clinical researchers need to prove that it's specific and sensitive, and typically the cutoff for what is enough in terms of specificity and sensitivity is above 80%. Does anyone know what was the sensitivity of the COVID PCR? Okay, someone say something. 65, higher or lower? Lower? Okay, sensitivity of COVID PCR is about 70%. Yeah. Specificity was higher, was 95 or something. So even something that was used all over the world as the gold standard test for COVID does not meet the criteria for the good enough biomarker that we use in psychiatry. So it's always relative, right? It's relative to what we have, to the best practice example, and also to what is more important. Because typically it's a trade-off between sensitivity and specificity. One goes up, the other goes down. And so you need to think with a test, is it more important to know for sure that someone has it, or to know for sure that someone doesn't have it, right? And in case of the COVID, I think they found it more important to make sure if it is positive, that it's really positive, that there is no debate about it, even if sometimes it may be false negative. The outcomes of such tests are described in these types of curves. These are ROC curves, where you have the sensitivity on this axis and the specificity here. And so typically, and this is chance. If your biomarker falls in this line, this is just chance. And then the more it goes to this corner, the better it scores. And so the 80% mark would be around here. That's where we want to be. Okay. Now, how do we approach this in practice as clinical scientists? Well, I can tell you what I did at the beginning of my career 10 years ago and what didn't work. So what we typically do is we take, for instance, we want to find a diagnostic marker of, let's say, schizophrenia. So I take 50 patients, 100 patients with schizophrenia, and then 100 patients with something else, or just healthy controls without psychiatric problem, and I compare, right? And then I look for a certain signal from cytokines or genes or whatever, and I hope to find something like this. These are Gauss curves, so normal distributions, and I hope to see when I put the results in the graph at the end of the research, the healthy controls here and the patients there, and then it would be end of story, we would have the fantastic biomarker of schizophrenia. But that's not what happens, right? Typically we see this. Whatever we measure, like if you're starting a project tomorrow and you're going to measure whatever biomarker in a setup like this, group 1, group 2, I can already predict the result is going to be this. That's what we always find. And even under optimal assumptions that the groups are more or less equally distributed and all of that, which is not typically the case, you would need 1.7 standard deviation difference between these two groups to get to that 80% accuracy level that we are looking for. So that's a really high bar. And to put that into comparison, why it's so difficult to move from group level statistics to individual prediction, this is a graph of male and female height, just body height, right? Distribution in the population. Would you say that based on just height, it would be accurate to classify, if you knew nothing about a person, just their height, would you be able to accurately classify them as a man or a woman? Would you feel that that is sufficient? Still, this is around 86% accuracy. So, what we are looking for with our psychiatric biomarkers is less accurate even than this. And still here, I think all of us feel that, no, it's not sufficient. Because this would lead to a misclassification rate of 14%. 7% of women would be classified as men, and 7% of men would be classified as women, and I think we would feel that this is not sufficient. So this is the complicated translation of findings significant group, this is highly statistically significant, like the p-value is definitely significant. So statistical significance is not the same thing as having a good individual prediction, like how well can we classify an individual. And it becomes worse as the variance within a group becomes bigger, and this is shown here in the chart. So here again, two populations, two Gauss curves. The average of the two populations stays the same, but the variation becomes bigger and the accuracy goes down. So the bigger the heterogeneity within a group, the lower your accuracy will become. And this is why we keep getting into the trouble with our psychiatric case control studies. The sample sizes are typically too small, they're cross-sectional, and they're very heterogeneous. And then you end up with something like this. And this is not my work, by the way, but I have done many studies like this, and they all show the same thing. So you have, two box plots. And well, I mean, there is a difference. You can see here the healthy controls are a bit higher than this is bipolar patients, and there were some genes that they measured. And it was, I think, statistical significance here, but you can see there is a really big overlap and also a very big range. And so in your ROC curves, that translates to just not good enough. Yeah, that was the mark, and we missed it, or they missed it. So what can work, what is a better approach, is to move away from just looking into case control studies to using all of the clinical data. Much more data, trial data, clinical records, what you're doing, basically, you were ahead of the curve. So we have larger scale cohorts, and even better if we can then pool data from different cohorts, even internationally. Move also away from cross-sectional to longitudinal designs, because we don't have the gold standard diagnostic classifications. It will be much more informative if we have data about how patients evolve over time. There is such clinical richness in that data that we can use. And instead of going for two heterogeneous groups of patients that with bipolar, but we know that bipolar is actually different things, and same for schizophrenia, there's overlap. I think it makes more sense to just move towards transdiagnostic designs, just remove the barriers and put it all into one analysis, and then try and find clusters of people with similar biological profile and similar clinical evolution over time. And this way tell us a lot more. So we need biomarkers for smart outcomes, clinically relevant outcomes, specific, measurable, analyzable, relevant, and transdiagnostic. For instance, so instead of trying to predict diagnosis, we could predict mortality, or suicide, or relapse rate, or hospitalization, or infections. Or we could look at treatment response. I don't care if it's MDD or BD. I want a group of people all taking lithium and then seeing who responds to what, right? Because it may be a shared treatment mechanism. Clinical trajectories over time, super valuable. So yeah. And the good thing is you're already doing all of that. So I'm really very excited about the future of what will come out of the data collected within the expert clinics. One small word about machine learning. I know so some people are very optimistic about the whole machine learning and AI and say, well, you know, we've been struggling for so long, but now AI is going to solve all of these issues. And then some other people feel that, well, you know, this is just a black box. We have no idea what's happening there. As always, the reality is somewhere in between. Garbage in, garbage out, right? So the value of your AI model is only going to be as good as the training data that goes in. So AI is not going to solve the issue of bad data. It's not going to solve the issue if we keep saying, well, this is schizophrenia and this is bipolar based on DSM categories that don't exist in reality, in biological reality. So you need to think really good about the training data and also about the validation. How are we going to validate that this model that we created based on the training data, it actually works in general and not just on the training set? Because AI tools are very good at modeling whatever you have, but that doesn't mean that it translates well to another context. I'm going to skip this. Yeah, and then so ideally use different approaches side by side. Again, if you talk to experts in machine learning and you ask them which is the best model to use for X, the, the answer is always going to depend on who you ask. There is not one best method, and because we don't know which method is the best one, I think it's best to use just several ones and see if they all agree on the same outcome. And that's more or less what we did in some of our machine learning work. So this is work by my PhD student, Katrien Skorobogatov, on the IGIV dataset, also through the collaboration with Marianne Boyer and Ria Telmouza. So this was a dataset of 186 patients diagnosed with schizophrenia, 321 with bipolar, and 185 healthy controls. And our goal was to see, just do an experiment, if we gave to the AI, the machine learning, only the information from immune biomarkers, cytokines and kynurenines, would they accurately be able to say who's a patient, who's a healthy control, who has bipolar, who has schizophrenia, and who was actively symptomatic and who was stable and in remission. Just with that information, no clinical information given at all. We used two different methods for the validation. One was the nested cross-validation, and this means that in this whole IGIV data set, the model each time put apart a little part of it, trained on the remainder, let's say the 90% of the data, and then tested on the 10% remaining, and then scrambled again, split it up again, tried it again, and so forth and so forth. And the second approach is split set validation, and here you make the split in the beginning. You say, here, model, 70% of this data you can see. This is your training set. 30% you won't see to train, and we will give it to you only at the end to see how well you did. These were the results. So this is from the first validation, the cross-validation. In red, it's the healthy control versus the patients. The complete accuracy was 0.8, so actually above the 80% threshold that we were looking for. Acute versus stable, 0.7. Schizophrenia versus bipolar, 0.6. So we are relatively able, surprisingly, to predict who has a psychiatric diagnosis just based on immune markers. We are more or less able to predict who is acutely symptomatic and who is not, but differentiating between the two diagnoses, no, we weren't able to do that, which makes sense because there is a lot of overlap, of course, between these clinical conditions also at the genetic level. When we repeated this with the other validation method, we got a different results. Now suddenly the blue line, which is the acute versus stable, got 0.9. Fantastic, like we found it, right? Actually, we started with this, in fact. In the beginning, our methodology was written to use the split set validation, and we got this and we found, well, fantastic. But then we saw the other one, and it performed much worse. And so I think this indicates the issue with the validation methods. Depending on which method you choose, you may coincidentally make a split in such a way that it just happens to be, very good for the performance, but that doesn't mean it translates well to different cohorts. And so actually the gold standard to validation, if we really would want to make prove that it works and move it forward, is to take these results and use them in a completely different cohort. For instance, from patients from Germany, and see if it still works there, which we have yet to do. This is another paper that was just submitted. Some of you may have seen it and co-authored it by my student Tim Riedberg. He used data from FAS cohorts, phase cohorts, I think you say, bipolar, schizophrenia, and MDD patients. And here we did the other way around. So also with machine learning, we used all or almost all of the clinical variables that were available in your records across the 3 groups, of course, but because sometimes variables were present in one cohort but not the other one, so we needed to select the ones that were common across the groups. And then we wanted to use all of these variables to predict who has inflammation, who has CRB above 3, which is the cutoff for inflammation, because we felt maybe this is common, this is the same across the different clinical groups. And he also used 3 different types of machine learning methods to come up with this decision tree and the different variables that have the biggest impact. And so most of the variance of who has inflammation in your cohorts comes from obesity, comes from metabolic issues. Obesity is the biggest one, and then independent from that, an additional contribution from lipid problems, dyslipidemia, cholesterol, cardiovascular morbidity, blood pressure, and smoking, with also some difference between male and female patients. So I think these are interesting ways of using machine learning to answer novel questions without expecting the machine to solve the problem that we weren't able to solve, right? Okay. Moving to the immune biomarkers, well, the number 1 complicated system in our body is the brain, obviously. That's why we love psychiatry, right? We love complicated things. But the number 2 most complicated thing in your body is the immune system. So immunopsychiatry tries to combine the 2 most complicated things and still make sense in somehow. So obviously complexity and just trying to understand what exactly is happening is one of the big issues. Also some level of non-specificity, I'll come back to that. What is happening in the periphery versus what is happening in the brain, trait versus state, confounding, and then just also that we don't always know the relevant cutoff, because even in a healthy state, without any somatic or psychiatric problem, inflammation is not 0, right? So there is always some level of immune activation happening. But yeah, so what can we measure in terms of immune biomarkers? I think this picture was created by my PhD student together with Marion when she visited here in Paris. Well, there is this whole complex interplay of genetic vulnerability, infection, stress, then your stress response, cells in the immune system, the gut-brain axis, cytokines being produced by the cells. They can then go to the brain and activate microglial cells there. And then all of that has effects also on different downstream metabolites. So, this is, we have quite a good overview now of this whole interplay of factors and how it can lead to mental health outcomes. And we can measure all of that. We can measure the genes, we can measure infections, stress levels, microbiome, immune cells, cytokines, cytokines from the brain, kynurenines, oxidative stress markers, and then with some scans or anatomopathological tests, we can also even look at the microglial cell activation and dopamine responses. So all of these components, we're able to measure, but we are not able to make real sense of the directions and what comes first and what comes after and how it all interplays against one another, and then what is the best thing to measure if we want to answer a certain question. And well, I think it comes back to some of the things that we talked about regarding what is a good enough biomarker. I try to make my own little assessment of different types of markers that are typically being used and how well they score on these key aspects of performance. Also taking into account that some of the studies, especially these ones, are in larger sample sizes, and then some of the other ones there in smaller sample sizes. Typically imaging studies, microbiome studies, these are really expensive studies, so they're often in smaller sample sizes. And you will see, well, it's varied, but very often there is an issue with either the interpretation. For instance, in the genetics, I think from a technical point of view, this is very valid, very robust, very reliable. Like the analytical part, I think no worries, but it's the interpretation, like how do we interpret it? Because it's an interaction of different genes and polymorphisms and small polygenic increased risks and all of that. So we can't really translate that one-to-one with actual clinical outcomes. And then with different things like the kynurenines, we did so many kynurenine studies, and I became desperate after some time because we would send a sample to two different labs and the results don't even correlate. So there is a problem of the technical validity there. Yeah. And so, yeah, for a clinical syndrome like depression, for instance, where whatever we measure in this whole, story that I showed you, we see group level differences. We see group level increases in CRP, cytokines, viral antibodies, immune cells abnormalities, also in the CSF, the microglia. But then if we want to compare it to another psychiatric population, for instance, here MDD versus bipolar, it becomes messy. We cannot really disentangle anymore. And so this comes back to the transdiagnostic story. It's really complex and it's really non-specific. We find the same or similar things across different disorders. And also there is a real problem of not finding the same thing in the periphery and in the central level. It's of course very difficult to measure inflammation in the brain directly. We can do that with cerebrospinal fluid, but I think in France, just like in Belgium, it's quite hard to get lumbar puncture of psychiatric patients. We have some brain imaging methods to look at inflammation post-mortem and then some novel ways, but it remains really hard in human studies to look at inflammation in the brain directly. So typically most studies use peripheral blood-based measures, but they don't correlate well what is happening in the brain. For autoantibodies, it's very, very clear you need CSF to make the diagnosis. A negative test in the blood doesn't tell you anything. But also cytokines typically don't correlate well with CSF cytokines, and for kynurenines the same. And then even if you were to forget about that and just say, well, a blood-based marker is better than nothing, there is a level of state specificity. So we've shown again and again and again, especially in bipolar and in schizophrenia, that the immune state of a patient in an acute episode, in an episode of mania or psychosis, is different from when they're in remission. So you can't just say, this is the immune marker of schizophrenia. No, it depends. What state are they in? And also it depends with age. So age is an important clinical confounder. You may have heard of the concept of inflammaging. Inflammation increases with age. This is true in everybody, but it's especially true in people with severe mental illness. Also, sex is a confounder that has been overlooked for quite a long time, but now we are seeing more and more studies from animal research and also human research come out showing sex differences. So we need to have actually separate studies or studies that are stratified according to sex. And we've seen that also in COVID, by the way, that there were very clear differences where men had higher risk of having severe acute infection, whereas women have higher risk of having long-term consequences. And this is due to immune system differences. Menstrual cycle as well has an impact on what is happening. So not even do we have to split up by sex, but we also need to know where women are in their menstrual cycle, for instance. So it's so complex, right? How can we bring this to clinical practice? Well, we're trying, and this is the end of my talk, just to show you some hope and that it's not all in vain. And this takes us back to the beginning. CRP, I talked about CRP a few times from the cardiovascular diseases, is one of the oldest inflammation markers. It's very well known. It's also not really specific, but it's highly sensitive, very stable. And we also see that across cohorts, and it's been shown again and again and again in UK patients, in French patients from your cohorts, in Netherlands, around 1 in 3, 1 in 4 of patients with depression have a CRP above 3. And this is unaffected by the illness stage, so regardless if patients are in an acute episode or not, or if they're treated or not. So it's stable, it's robust. Same with schizophrenia patients, around 1 in 3 have a CRP above 5, but also in the general population. So it's not a diagnostic test. We cannot diagnose anyone with a mental health condition with CRP. It's increased, in all the conditions, and we cannot differentiate from the healthy controls, but we can use it maybe as a predictive biomarker to predict treatment response, and that's what we're trying to do. I receive a lot of criticism for using CRP, typically from scientists who don't work in clinical practice. And it's so outdated and it's so non-specific. And I mean, we have all these cool new omics, and why don't you just, use something more advanced? Well, it is still the only validated and FDA-recognized marker of inflammation. You can measure it in any lab in the world. It's super cheap. And it's already being used in cardiology, for instance, for risk stratification. So this is CRP against your risk of a future cardiovascular event. Clearly, it's linear, but they still created some cutoffs and got them recognized for use in clinical practice. And this is used in GPs' offices today, based on the work that was done by the cardiologist. It's stable across the day. This is interleukin-6. The other big marker of inflammation goes up and down all the day. This is CRP. It stays stable, right? This is my pep talk for CRP. So I think when we look at CRP for these criteria that I told you about earlier, it's not performing all that bad. It's actually doing pretty well. The only thing that we're lacking a little bit is the interpretation for psychiatric problems. But we already have some evidence showing for our regular psychiatric interventions, antidepressant treatment, antipsychotic treatment, lower response if you have pre-treatment high CRP, and also a higher response to ECT, for instance. So that's very exciting. Here again, evidence of that. So this is a study from the Netherlands, where they pooled data from 4 clinical trials. And across the 4 trials, CRP was the strongest predictor of non-response to SSRI. So now it can become a really cool story. We have a group of patients with depression. In this case, depression is the most studied area in this field, but it's not going to be the only one. It's just because we have more data now. But so let's say this is a group of patients with depression. Around 1 in 3 we would expect to have this immune-mediated type with increased CRP. We know that these guys don't respond as well to SSRIs or regular antidepressants, right? So it makes sense that if we want to test in a clinical trial a new anti-inflammatory medication, that we shouldn't give it to these people, but we should use the biological marker or a specific symptom profile that we identify to give it to these guys, right? Unfortunately, that's not what happened so far. There have been quite some trials with anti-inflammatories for depression. Results are mixed, and that is because they were all done in unselected patients. And then, of course, if 1 in 3 or less or more, depending on luck, has the right phenotype, yeah, then you can imagine that you get mixed results. But we are getting there, and there is also already some proof of concept that it may really work. So this is a study from the UK where they did post hoc stratification by CRP. So they didn't, in the beginning, only give the treatment to people with high CRP, but after the end of the study, they looked who had high CRP and if it worked better, and it was in fact the case. So this was with minocycline. That's an antibiotic that also crosses the blood-brain barrier to stabilize immune cells in the brain. And it only worked in the people with high CRP. This is high CRP in minocycline. This is low CRP in minocycline. And the height of the bar is the change, improvement of depression symptoms over the trial. This is a second study. Here they used N-acetylcysteine, which is an antioxidant. Same thing, it only worked in the people with high CRP. This is a study of infliximab, a cytokine inhibitor, also only worked in people with higher CRP, and it was a linear effect with the cutoff around 5. But not always. 3 trials have been negative. The PREDICT trial did have a stratified design, so they tried to make this differentiation from the beginning, but the study was ended, earlier because of COVID, and they didn't recruit enough people in the high CRP group. Only 19 got high CRP and celecoxib, and so the sample size was just too small. And then the MINO-TRD trial, this is again minocycline, but here they didn't select for anything, and they did a post hoc analysis, but with a median split, where CRP level was 1.2 and not 3. So also they didn't find anything. So the jury is still out there, we don't know, but we may know in 1 or 2 years. Because this trial is going on in the Netherlands, and they will end it this upcoming spring. So they'll have the results by the end of 26. They're doing a trial of antidepressants plus celecoxib, which is an anti-inflammatory drug, and they're including patients with depression and a CRP above 1, plus clinical symptoms that we believe are associated with inflammation, like fatigue and energy-related symptoms. And at the same time, we in Antwerp are doing this clinical trial with celecoxib and also minocycline head-to-head, where we stratify based on the CRP. And of course, we hope to see the effect in that high CRP group. But that will be for 2027. And also, internationally, while these other trials are ongoing, we are trying to get access to as much clinical trial data from past trials as possible to reanalyze them. Because even if they didn't select for the high CRP patients at the beginning, maybe we can get the data from the trial, separate the groups based on CRP, and then see if we find the treatment results. And if we pool enough data from enough studies in such a way, maybe we can already see if it works. So this is happening in the Aspire consortium, where Professor Marion Laboyer and myself are also involved. And so yeah, this is the end of my talk. I hope that I've convinced you that we do need immune biomarkers, even if it's complicated, and we need them because it's the best way forward to move towards precision psychiatry. So we're not just doing that because we're interested in inflammation, we're doing that because it has an impact on clinical management, because these are the patients who don't respond very well to our current treatments and who may need something else. So really having this approach may be beneficial for all patients in the end. And I think you agree with me that it's highly needed. Well, if anyone has data around that topic, there is a special issue of BBI right now. I'm co-editor there, so let me know. And, otherwise, I will thank all of my collaborators and also collaborators from INSERM, and wish you a very interesting 2 days, and I hope that I've motivated you why your work is so important and so powerful. Thank you.
Fabrice Bernard from Strasbourg. Thank you very much. I have one question regarding the CRP. You mentioned that you think it's a predictive for treatment response for some specific aspect of not only treatment response. Could you give maybe the sensitivity or the predictive value of just to see in which way we can analyze the value we have on the lab report and how can we predict the response?
Yeah, so as explained, group level differences are not individual prediction. So we're currently at a group level outcomes stage, of course, and we hope to move within next year to the individual prediction stage with the work that we're doing in Aspire. So I can't tell you sensitivity specificity yet, but I can tell you the relevant cutoff to look at, not to already change your clinical practice, but just to be aware. So we are using in our work always the cutoff of CRP3, and this is high sensitive CRP. So it may be, depending on what is on your lab result, that you see lower than 5, and that the cutoff is 5, just because it doesn't go lower than that. This is the technical sensitivity. If you have access to high sensitive CRP, typically it's in an additional box that you can cross on your lab recipe. It costs a little bit more, but it's more sensitive. And this is the relevant value that is also used in cardiovascular diseases. So CRP above 3 or high sensitive CRP above 3 is clinically meaningful already from a somatic health perspective. I cannot tell you if you see CRP above 3, don't give SSRIs. But I think it's relevant if you have someone with depression and they've not responded to SSRIs or they've not responded to antipsychotics, and you see also a CRP above 3, to be aware. It could be related to inflammation. Then the next step could be to consider, together with the patient, what are the potential sources of inflammation that are keeping on the problem? Is there a metabolic issue that we can fix? Is there a problem of post-infection disease? Is there an autoimmune condition that is not well managed? Is there, I don't know, some other kind of exposure that we can solve? And then, but this is still, a bit experimental, I think, but we have seen better results with dopaminergic agents in people with depression and inflammation. And this seems to be because inflammation has an impact on dopamine pathways. So bupropion or anything more dopaminergic may have a better result. Yeah, and then I am already using sometimes celecoxib or minocycline in clinical practice, but that's because in Belgium I'm allowed to do that. So I'm not sure if you are in France, but maybe Marion can comment if it's too early to move that way. But in any case, if there is any suspicion of something autoimmune going on, refer them to the endocrinologist, the rheumatologist, the immunologist, or to the immunopsychiatry practice. I hope that you still do. Yeah. We see so many patients with undiagnosed autoimmune problems. It's really a big problem, and we need to advocate for our patients as well, because typically the people working in somatic fields don't necessarily understand all of this concern and why it's important, or they may not be familiar with the presentations that we know. But so yeah, it's ongoing, and maybe in 2 years I can give you an actual sensitivity and specificity. That'd be great.
Thank you very much, Ariel Fregerman. I have a question, because you say studies about celecoxib or other, but there's another anti-inflammatory agents, omega-3, and there are a lot of studies of omega-3 supplementation for the anti-inflammatory and antioxidant effect. So do you plan to try it also?
Yeah, that's indeed. I mean, this talk was not about interventions, so I skipped all of those slides, but I have slides on that at home. So in this project, we are doing a big systematic review and reanalysis of all trials of previous anti-inflammatories, including the omega-3 trials, and there are a lot of them. It's actually more than half of the studies that we found. I think more than 80 or something. And yes, we are planning to reanalyze them as well to find if there is prediction markers for the treatment response, and if that can also then be a tool for clinical practice. I think if your patient is in favor of trying it, there's no harm in trying. It's very safe intervention. I don't believe for really severe mental illness that this is the solution, but maybe in addition to other lifestyle intervention, for instance, and psychopharmacological treatment, yes, why not? Yeah.
So maybe just to conclude, Livia, if you had one advice to give to all the clinicians about what to do and to whom it should be done, for example, should we have a systematic assessment in patients with resistant psychiatric disorders, and then what should it be, and what type of treatment can we today use, or strategies, because it's not always treatment.
Yeah, well, based on the data from your own cohorts that our student has worked on, I think it's critically important that we start measuring CRP at the very least. If you want to measure anything biologically, measure CRP and then go from there. If it's increased, go and measure why it's increased. Measure glucose, measure cholesterol levels, measure BMI, and then take steps depending on what you find, of course. And this is not completely novel. We know that it's important to treat psychiatric patients well also in terms of their physical health, so we're not doing anything experimental here. It's just being more aware and advocating for them. And I think should we measure CRP in every psychiatric patient? Well, yes, why not? I think these patients deserve to have at least one lab measure done at the point of diagnosis. But if that is not possible, at least after a first round of treatment if they've not responded. So yeah, that would be my advice.
Et juste un petit mot de conclusion, puisqu'on a parlé un petit peu des maladies auto-immunes. Donc, je vous rappelle qu'on a un essai clinique auquel un très nombreux d'entre vous participent, qui s'appelle Team des pistes. Tous les patients qui sont positifs aux anticorps anti-NMDA n'ont pas toujours une CRP élevée. Je ne sais pas pourquoi, on n'a pas encore regardé de façon systématique, mais je vous rappelle que la clinique prime et qu'il y a vraiment un tableau clinique spécifique des patients qui sont porteurs d'auto-anticorps. Donc, n'hésitez pas, ce n'est pas des mesures très compliquées. Ça se mesure dans le sang et pas dans le CSF. On se disputera après avec Livia parce qu'il y a un petit désaccord sur encéphalite versus psychose, mais c'est vraiment un sujet important. Et donc, n'oubliez pas qu'on nous reproche beaucoup de tester des biomarqueurs en ce moment. Vous avez vu ça dans beaucoup de journaux, mais la clinique prime. Donc, on a un tableau clinique spécifique. Et là, il y a deux grands tableaux dont il s'agit aujourd'hui, la résistance au traitement. Quand on a un patient résistant, ce n'est pas que dans les centres experts dépression résistante, on se doit d'explorer toute une série de comorbidités ou de causes biologiques qui ne sont pas suffisamment prises en charge en France. Et quand il y a un tableau clinique évocateur d'une psychose auto-immune, s'il vous plaît, envoyez-les dans vos centres ou à Bordeaux ou à nous pour tester des auto-anticorps parce que les traitements ont vraiment l'air de guérir les patients. Donc, il y a un espoir considérable avec tous ces marqueurs. On en est au début de l'histoire, même si ça fait 10 ans qu'on travaille là-dessus. Mais vraiment, c'est un domaine où on va trouver des tableaux cliniques spécifiques, on va trouver des biomarqueurs. On a des traitements qui peuvent être soit des compléments alimentaires, des stratégies thérapeutiques d'amélioration de style de vie, mais aussi du repositionnement de toute une série de molécules. On vous parlera beaucoup l'année prochaine de syndrome métabolique, qui est quand même à l'origine de la première cause de mortalité de nos patients. Donc pensez-y sur les centres experts ou dans votre pratique en dehors des centres experts. Il y a vraiment beaucoup de choses qu'on peut faire tout de suite aujourd'hui. Un énorme merci à Livia, qui a été remarquable comme toujours. Merci de votre attention.